Hello everyone and good evening. I'd like to welcome any new participants as well as welcome back any of our previous participants. And before I introduce myself, I'd like to bring your attention to the poll that I will bring up on your screen momentarily. So the poll in question asks, which professional role do you represent? So I'd like to say that it's my pleasure to welcome you all tonight to our interprofessional virtual grand rounds presented by the American Academy of Developmental Medicine and Dentistry. My name is Michael Tarr. I'm a third-year medical student at New York Medical College, and I am the AADMD virtual grand rounds facilitator. So I'm going to close our first poll and share it with you all. So we have, joining us tonight, 6% of our participants are working in administration, 17% are students, 6% are working in medicine, 44% are working in dentistry, and 28% are working in other. So I'm going to open up the next poll and continue to introduce you all. All right, so our next question is, in what stage of your career are you in? So the AADMD Virtual Grand Round sessions seek to create a space for mentorship and exchange of knowledge and experiences between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any question that you have for the presenter. Questions can be submitted through the Questions tab on your gray control panel on the screen. So I'm going to close this poll. And when we asked what stage of your career are you in, we found that 5% are in pre-health professions training, 29% are health professional training, 14% are in their residencies, 48% are currently practicing, and 5% are retired from practice. So I'm going to expose our final poll. And the last question asks, what do you hope to gain from this webinar? All right. So at the end of the session, we will send you a link to a quick survey we've made. It shouldn't take more than 5 minutes, but it's very important to us that you do fill it out. The feedback we receive from you through this survey allows us to improve the virtual grand rounds and also to hear what future presentations you'd like us to have organized. So let's close this poll. When we asked you what you hope to gain from this webinar, we found that 23% said they are looking to learn foundational health care concepts for individuals with IDD. We found that 45% said they are looking to gain interprofessional perspectives on health care for individuals with IDD. 27% said they're looking to gain pearls from complex and challenging clinical cases, and 5% said they're looking to gain CE credits. Okay. And finally, I'd like to introduce tonight's presenter. So the presenter for tonight's virtual grand rounds is Dr. Kelly Krekel. Dr. Kelly Krekel attended Binghamton University and obtained a bachelor's degree of science in bachelor's of science in neuroscience, where she also conducted research on Wernicke-Korsakoff syndrome. She graduated in May of this year from Stony Brook University with a Doctor of Dental Surgery degree, and she is currently in her first year at Stony Brook University's Pediatric Dental Residency Program, and she is dedicated to treating individuals with intellectual and developmental disabilities. And with that, I will hand the floor over to Kelly.
Okay. You can hear me, right, Michael?
Yep. Sound good.
Okay. Hello, everybody. Good evening. I'm Dr. Kelly Krekel. I am a first-year pediatric dental resident. I actually went to Stony Brook University as a student and also now in residency. And today we're going to be discussing the value of nonverbal communication during dental visits for individuals with IDD. And I just want to preface the whole PowerPoint by saying that so we are talking about a dental setting. However, our hope is to have other healthcare professions extrapolate some of the techniques that we use in their clinical practice as well. Okay, so let's get started. So our goals for this presentation, the first thing I'm going to talk about is a little bit of the background on treating patients with IDD. We will kind of go over why this group is underserved and why some of the training is lacking for our healthcare providers. We will then go into some studies on IDD patients and their social perceptions. We then have the video of Dr. Fred Ferguson. He is using nonverbal communication. It will be a muted video, but you'll be able to see all the techniques that he does in this dental setting, and hopefully, again, be able to extrapolate some of these techniques and use them in your clinical practice. So the idea of the video for my research is to allow students and residents to gain information through actually watching another healthcare provider use the clinical techniques, as opposed to just reading in a textbook. The next stage will be, we're going to go through the video kind of in depth and talk about the techniques that were employed by Dr. Ferguson, and then we're going to have about 15 minutes or so for a discussion and a Q&A. Okay, so treating patients with IDD, a little bit of background. So we know that these healthcare services are going to be a little bit more difficult for patients with IDD. And typically, they will have a significantly worse health-related quality of life than those in other segments of the population. And this is really due to the lack of initiative on the part of the healthcare providers to open up their practices to treat them effectively. We will usually need longer appointment times because of, for obvious reasons, we need to use different techniques, and it can be a little bit of a slower process. We need specialized clinical training, not only of our providers, but also of our staff and the people that are in our office. We would need specialized equipment. So we're going to go into all the different protective stabilization equipment that we use in dentistry, but things that can also be used in other healthcare professions. You also may need wheelchair accessibility and things like that in your office. So again, some healthcare providers may not have that available. And there's obviously no financial incentive for these things. The insurance companies are not going to pay you extra just because you are treating patients with this, but it is our duty to obviously treat all patients, but especially an underserved population such as the patients with IDD. So things to keep in mind when we're treating patients with IDD. So they're usually more than likely going to have complex medical histories. They could have complex dental histories, nutritional needs, and a lot of them, or most of them, will have behavior issues. This could include sensory or motor impairments. They could have social and communication deficits. They may have self-injurious behaviors. And you can see in some of these pictures, they may do things such as rocking back and forth. They may be flapping their hands. They may be covering their ears. We'll kind of go into why some of these behaviors occur, although I know a lot of you are very interested, obviously, in this population, so you may know even more than I do. They may have gaze aversion. These are all things that if a healthcare provider, and including even staff members in your office, if they're not trained to see these behaviors, it can really be misinterpreted and can lead to non-productive treatment. And so we want to have good training, like I keep mentioning, and this is the presentation that we're hoping that will occur in. Some a little bit better training. So some of the things we can do, right? So we can increase the training program's didactics, which is, reading in textbooks. We can have students, follow lectures and things like that about treating patients with IDD. But the real knowledge is going to come with practical experience. And I think as healthcare providers, we can all say that the majority of our training came from the practical experience in a clinical setting. And our goal, at Stony Brook as a student and now as a resident, we're very keen on taking these patients in a clinical setting and trying to do as much treatment as we possibly can on them before we go to general anesthesia or IV sedation. There are instances where there's too much treatment to be done and things like that, that we now have to look at general anesthesia or an OR case, but up until that point, we should be able to treat patients, especially as far as dentistry, cleanings and exams and things like that could be and should be done in the clinical setting. So, and that practical experience can be done in many ways. A lot of times you'll have sort of specialists within institutions of IDD, but with Dr. Ferguson's video, hopefully it can go out to the masses. That's kind of our goal, and students and residents will be able to see how he, who has been in experience for 40 years with this, is able to use these techniques and get treatment done effectively and safely, and he feels the same way about this too. That's kind of our goal with this. And we do have some behavior management goals that we're going to go into besides just nonverbal and verbal communication. But our number one behavior management goal, so it's safety, right? Every clinical setting that you have, your number one priority should obviously should be safety. And that's safety between the patient, obviously, but also the doctor and the staff that are helping you. And we're going to see in the next slide that some of the protective stabilization that we use is for safety. Okay. Discovery is mine and Dr. Ferguson's favorite word on here, but it's the second most, we'll call it the second most important part of your behavior management goals. Dr. Ferguson uses the term blind date, which is a very endearing term, but it means so much. And this is exactly what it is when you first meet these patients. You don't know what you're going to get. You are going into this setting with them, and the first thing that you do is make eye contact, and that's where your discovery begins. You're going to see the attitude of that patient and the attitude of that caregiver, okay? So that patient's going to walk in. They may have had the worst day ever, the worst morning ever. They may be really happy. They may do this all the time, and they're ready to go. They may know everything about dental, they may know everything about medicine, they may know everything, the caregiver may know nothing. So you have to discover between the patient and the caregiver what we're doing here before treatment even begins. So this is way before, and this is when you're going to start to learn, okay? The behavior obviously is important. If that patient is already screaming and crying, you're in for a little different experience than if that patient comes in twice a year for the past 20 years and they know exactly what's about to happen. You want to also know the skills of the caregiver. Is that caregiver at home with that child every single day, brushing twice a day, effectively? That child has never had a cavity in their lives. Or is this caregiver, have 10 other kids that they're watching, or are they in a group home setting? You never know what you're going to get, and that's why he calls it a blind date. So you kind of discover all these things, not even just talking, but that's what nonverbal communication is. You're kind of watching between also the patient and the caregiver, their little unspoken conversation between them, their nonverbal communication between them, and what you're going to get. You're discovering all of this before your treatment even begins. And then the next thing we're going to talk about is informed consent. Everybody, usually healthcare professionals are very aware of what informed consent is, but what we're talking about is informed consent that has to do with behavior management specifically. So protective stabilization. Again, we're going to get to it. You're going to see what we use in dentistry, papoose, arm guards, knee guards. These are all things that the parent and the caregiver have to be prepped for before they see it, because it could be a little bit daunting. And you're going to see that it's a wrap. Some parents will come in, oh, I don't want the straitjacket on my child. Well, it's not a straitjacket. It's a protective stabilization device that we use to keep your child safe. All these things have to be written out and spoken to the parent really, really ahead of time. So that way when that treatment begins, there are no surprises. And that's one of my bullet points. There are no surprises. Another thing that you want to get, there are two more things I want to talk about you want to get consent for. Voice control is one of them. So in this population, voice control, well, let me say what voice control is because we may not use it throughout all of healthcare professions, but in dentistry what voice control is not yelling at a patient, but simply raising your voice in a stern way that patient will understand that you're the authority. And in some patients with IDD, depending on their intellectual level, they may not pick up on that sternness, or they may not respond well to it. So you kind of have to gauge, and that also comes with the discovery phase of how is that patient going to react to me speaking to them normally versus me speaking to them with sternness. You have to, that's all in the discovery phase, again, way before treatment. But you want to make sure that the parent or the caregiver is on board with that, and I can't tell you how many times it happens in our clinical setting where a parent will come in and said, oh, Dr. So-and-so yelled at my child. I will not see him or her ever again. And of course, I'm sure that dentist was not yelling at their child, but simply using voice control, but apparently they didn't, inform them ahead of time that was going to happen, so it doesn't always work out well, and mom goes, all right, we're out of here. So then treatment's off, you've just, we kind of just blew the appointment, and that's really our bad. We have to kind of take responsibility that we didn't inform the parent or the caregiver about that ahead of time. Another thing that you're going to see in this video with Dr. Ferguson is that he is always in contact with that patient physically. So he has, although he's a dentist and we normally work above the neck, he does have his hand on the patient's back or shoulder or chest, and that's to establish a certain level of contact with the patient and control with the patient. We'll talk more about it later after the video. But you have to let the parent know that that may occur and see if they're okay with it. And you don't have to say we're going to be touching your child. That would be, I think the parent's going to call off the treatment immediately, but you have to make sure that the parent's aware that we are in a very close setting. Of course, this is dental. We're right up in their mouths. We couldn't get any closer, and they have to be aware that we do things a little differently to make sure that this treatment is a success, that the outcomes are good. Our goal before treatment starts is to have the trust of the patient and the trust of the caregiver. We're doing this together. We're doing it through a guided, shared experience, and if we have a vision of how this is going to go together and it's all the same, we have a really good outcome. Okay, no surprises. So this is the protective stabilization we use pretty much every day in at least my residency training. And we are able to use elbow and knee stabilizers, which are the yellow, green, I think my cursor works. Yeah, so the yellow, green, blue, these are arm, elbow, and knee stabilizers, and they don't allow for the arms and knees to bend. This is the papoose wrap for a child. This is one for an adult. Sometimes they have a board underneath. This is a pillow, simply because some patients can't lean their head back so far, so we have to be aware. We have to have different things in our arsenal for different types of patients and different types of syndromes. Some syndromes, they can't lean their head far back, such as in Down syndrome. We have to be very aware of that. And the head hold. So this is the probably one of the most important things that I have learned in my training is that head is basically a football in your armpit when you're treating a patient. And I know in dental, again, we are in the closest proximal space to that patient, that personal space, but that is the only way you can maintain control, stability, and safety for that patient. You are moving with that head. There is no way your Explorer or your mirror or even your local anesthetic syringe is going that you don't know it's going. You're moving with that head. You're in that stable position knowing when it's happening. And so that is a perfect example that Dr. Ferguson has there of a head hold you also see in the video. Okay, so some studies about patients with IDD that I was just, taking a look at that relate to dentistry. Overselectivity was this is the title of one of the studies, referring to the maladaptive pattern of behavior of overselecting a limited number of stimuli from those available in the environment. Okay, so they're over-focusing on certain things in the environment and focusing their attention on it. And this could trigger anxiety, it can trigger, a different behavior that that isn't going to work necessarily well for us in a treatment setting. And we have to be aware that in dental, especially, again, I feel like a broken record, but in dental we're right up in their space. And we also have sounds and lights and smells and tastes. Everything is going on around them, and if they are triggered by something and it sets off their anxiety, we could have just lost them in what could have been a really great treatment appointment. So you have to make sure that you're aware of what's going on around them so that treatment goes effectively and they're comfortable, okay? We don't want to cause them any undue anxiety. Another article that I thought was interesting relating to the way that they socially perceive things is, autistic patients, perceive things non-communicatively is by this author, the researchers Eldak et al. In 2016 saw that social cues between neurotypical patients and autistic patients were very similar. Their perceptions were very similar. And so they kind of did this in a very interesting test. So they used cues. The cue was a hand pointing in a certain direction. And they measured the amount of time it would take for the eye to register in which direction the object, such as an apple, was. So it was either in the same direction as where the apple was, or it was in the opposite. And in a neurotypical patient, it would typically take a little bit longer for the the eye to register that it was in the opposite direction. Well, this is apparently the same in autistic patients, and so they related that social cues are perceived very similarly, across the board. However, there was increased mental effort for these patients, and so we understand that although they kind of see what's going on, and they can recognize that things are going on in front of them socially, they may not be processing it, as easily as we are. So what do we have to do? We're in a setting where we're trying to make sure everything goes smoothly, so we may have to go a little bit slower. They're learning at a little bit different pace than we are, and so we want to make sure that every step of the way we're kind of going at that same pace with them. And this will also build a trust with the patient. If you're going too fast, the patient may not feel ready for the next step and lose trust in you. And again, we're always trying to look for that shared trust so the appointment goes really well. And the caregiver obviously will appreciate that as well. All right, so this is the video of Dr. Ferguson. I'm going to play in a second, but I just want to preface the video with a few things. So this is approximately 15 minutes long. We may not go to the very end of it, but Dr. Ferguson, he's, like I said before, has 40 years of experience in pediatric dentistry and patients with IDD. Amazing clinician, professor. He's a distinguished teaching professor. You're going to see him in this setting. Okay, so this is like the pinnacle of how patients should be treated, and even sometimes he has trouble treating these patients. So, and you're going to see that in the video. Some things aren't working as well as you think they are, and it's really kind of interesting to see that no matter what you do, even if you've had all the experience in the world, for different patients, different things work. But I want to draw your attention to a few things. So I'm going to use the cursor throughout the video a little bit just so that I can focus your attention on certain aspects. I'm going to have you ask questions on the questions tab of your control panel so that they come in a nice order. There's two types of ways that you can ask questions in the chat versus the questions. Again, I want it in the questions tab if you could. And I also want to preface this video by encouraging you to focus on certain things that you probably wouldn't do, you would think would be done intuitively, but they're not. So this is training. This isn't something that people naturally know how to do from birth. They don't naturally know how to treat these patients. We all know that. But especially in these settings, these are things that they're not intuitive. So if you're going to see children screaming and crying, and their faces are turning red, and they could be spitting. A lot of people would say, okay, this is too much. Let me stop. This child's screaming. Well, that's not the case in dentistry, because now we have an opportunity to look in the mouth. You have to realize that we like when the mouth is open and they're screaming, unfortunately, and you don't ignore it in a sense of, that they're crying, but there's obviously a difference between a pain cry and an anger cry, and you're going to see Dr. Ferguson doesn't break that character at all throughout the entire, all the procedures that you'll see. These are a few different scenarios. You're also going to see that he, like I mentioned before, has physical contact with that patient, and how, it's very apparent and how it really works for him. And that also will come with experience and that comfortability with getting that close to a patient. You'll see that in the video. And again, I want to also mention that at Stony Brook, we are really encouraged to treat patients in a clinical setting, you want to interact with them. We don't want them to be sedated. We want to really get that training of them alive and in our, I shouldn't say alive, that are interactive with us in that clinical setting. And we go to as far as it takes us until we really can't go any further, and we have to say, okay, this patient's going to go under general anesthesia. But I encourage you to think that way, and hopefully be a little bit inspired that you too can honestly do this. Because with the training, it's not for everybody, but I think that definitely more people than now will be more comfortable with doing this with better experience and a little inspiration that they can do it. So we're going to start the video, and I hope this works. So we're going to mute the video, and I am going to just let you guys watch it. Any questions, please put in that question tab. You probably hear typing, everyone. I'm just answering any questions that people have. And so far, someone just had asked a certain question about the practice without pressure, philosophy, and process. I'd definitely like to go over that in the Q&A later because I'm curious about that. And then someone had asked, why is he constantly touching him? We'll definitely go over that afterwards. So we'll definitely, anything nonverbal communicative, hopefully I pick up everything that you guys see, but we will talk about it at the end for sure. And also it's muted. I hope I said that before, but it's, yeah, you don't need to hear the dialogue. I want you guys to focus on nonverbal communication. So I'm actually going to turn the sound on for this part because I want you to hear how he coaches the child into that protective stabilization.
Right, I tell you what, you're going to sit right there. Okay, sit. And just take them above the knees. That's right. And use this. Here we go. Take that wrist too. Here we go. Absolutely. Get the back. Okay. This side. Wow. That wrist so he doesn't get out of that. Okay, let's unwrap this. All right, Bob. Take this off. Let's put it back. Okay. Now, Bob is another guy who we've done care for in the operating room, but we've also treated him here under some arm guards, leg guards, and the peplums board. But his last care, I believe, was done another like block time yesterday. His other care, I think, was on the operating room, right? Right, yes, yeah. Go ahead. So, again, mom and dad are maintaining his hygiene pretty good. His visual health is good. He's missing a number on the adult feet. But they coming out okay. Okay. Thank you. Okay. Okay. So, Bobby, come on, bud. You're all right. You're okay. You're all right. Slow down. Thank you. Okay, Bob. Slow down. Okay. Okay. Guys, keep his mouth really clean. There's no decay, but the new teeth are coming in. Okay. So the thing I'm mostly concerned about is one. Okay, thanks. Is one that you really work at brushing the lower teeth around behind them. Okay. And the new upper teeth that come in, you got to really scrub around those two, because that's the only place I think you're going to get in trouble. You ready to go? You ready to go? Let's go. All right. Come on, let's sit up. Let's sit up. Come on. All done. Sit up. Come on, let's take this one off. Let's take this one off. Okay. Came off. There we go. Okay. You have this all right. Let's take this one off. Thank you. Where are your buses? Where's the bus? Where's the bus? Oh, I'm going to find this bus. That's the drug. Here we go. Here's one. Oh, there's the bus. Where's the other one? Where's the other one? Yeah, very good. Take this to the bar. Okay, take it away. All right, that's it. You okay? You okay?
Okay, put this part in.
Okay. I think it's all trouble. We're going to get a liquid giant.
We're only.
Okay, okay. Yeah, we're going to have a seat over there. Right over there. His health is good. All right, good. It's going good. He's brushing his teeth when? My wife brushes his teeth. When? Morning, evening? Oh, at night. After school? In the morning and at night. Okay. Like to add after school now. Okay. Okay, because it's lunch at school and, add after school. Can't brush his teeth enough. What's he drinking most of the time? Mostly juice. Juice? Like what kind of juice? Good. Watered down. How much watered down? About a quart of water. Okay. Get it going. Like orange juice. Oh, orange, regular orange juice. Yeah, not the orange drink. No, no, no. Fine, that's fine. Orange juice is okay. But water down everything else other than milk. And cookies or nothing like that. Good. Fruit. Good. Starches, the junk, Doritos, that kind of stuff. Good. I like that stuff. Good. That's my man. All right. Okay, so we're going to look at the teeth, okay? Oh. All right? Good. You're going to take your carbon and come on, have a seat. Come on, sit. And he's letting you brush his teeth and whatnot. Right. That's what good job. There we go. This is the super tanker. Wow. Okay. It's okay. All right. Come on. Daddy's here. Come on. We're just going to look at Bobby's feet. There's one big chair. Okay. Let's look at Bobby's teeth. We're going to put the elbow and knee guards on. Oh, nice. Let's see what these legs.
Legs first?
Yeah, let's do that. Yeah. It's just an infection. We're going to put these, let's try, you know what? Like one of these guys, yeah. It's big enough where it'll be a challenge. Okay, have your leg kicked in. Thank you, Bobby. All right. Okay. It's okay. This is nothing. This is nothing, Bob. Don't worry about it. Next. There you go. Okay. I'm going to put one of the arms down. No, I'm going to use it because it has a cock here with this. Don't worry. All right. I got your call. All right. Stick this arm here. Thank you. Thank you, Bobby. Around there. Okay. Hold your car. There's your car. Thank you. All right. Good job. Thank you, Bobby. Good job. Okay. Put his legs to you. Okay. Here we go. Take this one. Okay. So again. Take his wrist, thank you. Yeah. Okay. There we go. Thank you, Bobby. We're all done. We're all done. Good job. We're all done. Okay. All right, don't worry. Okay. We're all done. Okay. You okay? We're all done with that. Thank you. That's all right. Okay. Okay. You did good. Okay. I'll set you up. Okay. There we go. Now, last time he was here, he was erupting his upper first molars. And they weren't quite thin enough for me to get they weren't quite thin enough for me to evaluate them. Right. And now that they're in all the way, I can look at them and I definitely feel seal it. I can get my score in there. And this graph is going to help a lot. And I'd like to see less upper molars. What do you mean by sealant? It's a coating. No, it's not a cap.
Okay, I'm going to skip ahead a little bit just because they're talking about the treatment. So I'm going to move ahead a little bit more. He gave him back his car. That's what happened in that amount of time.
Dr. Ferguson 5. Come on, bud. Yeah, that's it. All right. Well done. Well done. You guys are doing a great job. I mean, I saw a little bleeding aggression, but it went away right away, which tells me you're doing a pretty good job. One more time a day on my way. Yeah, after school, and keep the mindset. When his second molars come in, it's going to be probably a mid-teenager. You're going to be looking at those teeth, the same thing, the same thing. But the major thing is that you guys keep doing the push-ups at home, because that's it. That's everything. As he gets older, is there a way to have keep putting on the bottom? Is that something? Is there a way? Yeah. Should we do it? I don't think so. It's not worth it. Well, the reason is, I'm saying all those. No, but let's say the problem is not his age. The problem is that what do we got to do anything for him? I mean, this guy, he's a heavy hitter. So anything we're going to do, not going to do anything other than make it look for him. The most important thing is that we keep him healthy, clean.
Okay.
Don't let anything happen.
So, and the rest is just him speaking to the dad about, kind of how they're going to go forward and keep the teeth clean, everything like that, which is definitely half our battle, if not more. However, just with this, we're going to be talking, mostly about the non-communication and actually verbal communication. Excuse me, not non-communication, non-verbal communication and verbal communication that we observed in the video. All right, so because that could be a whole nother lecture if you wanted to talk about oral health, literacy, and things like that. So we won't go too much into that right now, but so let's discuss the verbal communication. Let's just touch on that because it is important. Actually, someone had asked the question, let's hear the sound in the video, so this was the first time when I showed the video to the residents to get the survey for my research. I am putting the sound on, and in discussing it with the faculty that I'm working with, they had said, let's keep it on mute so that people can focus on the nonverbal. But I think it's very important that this person said that because it's true. We really need to combine the verbal with the nonverbal to really get an effective level of communication for these patients. So I appreciate that, and in future presentations probably we'll just keep the sound on for most of the video. I hope it wasn't too distracting with all the kind of extra noise that was going on around it. We just created this video not too long ago, so we're also learning what people like and don't like, and so it's awesome when people give us feedback. Okay, so let's talk about a little bit about verbal communication. So in a lot of the video you saw that, and you may not have seen because like I said I had to unmute for a little bit, but he will be speaking, Dr. Ferguson speaking to that patient as if they're a neurotypical person. So why is he doing that? Because maybe some of these patients aren't really comprehending necessarily what he's saying. So that's another part of learning and another part of discovery. If you're talking to someone in the way that you would normally speak to someone, you can, by their response, gauge how they, how you should proceed. Should I continue talking the way that I normally do? Maybe they're picking up on everything. Maybe I need to repeat things. Maybe I need to go slower. Maybe I need to go faster. So that's why you would speak to them normally to get that learning experience for you. Showing appreciation is always important. These are people, obviously. You always show your appreciation if they're doing something correctly, but it also is a form of positive reinforcement. You heard Dr. Ferguson saying thank you, thank you. You really always want to thank the patient. They actually did, one of my co-residents, who I think is watching, sent a little a link that had research that actually is better for patients to hear you're a very good listener than to say, thank you for listening. So if they're a good listener, they associate it with, a role that they can play in life, and that actually leads to sometimes better cooperation. So that's for a neurotypical child, but we can also, again, these social perceptions, as we saw in that study, could be the same for autistic children, so why not potentially use it? So you want to show your appreciation. The caregiver cooperation, and this dad in that video with that child is all the caregivers are in cooperation, obviously, because Dr. Ferguson did his diligence and made sure that all these parents are on the same page with everything. But that dad, you can see, is right in that treatment, and he is playing that third-party role, Dr. Ferguson's helper in anything he needs. And again, that comes with informed consent and discovery, seeing where that parent is at. If they've done this before, they know, all right, he's the man, it's his house. Dr. Ferguson's going to dictate all the rules. I'm just a bystander. I'm just making sure my child or the patient that I care for is being treated properly and safely and effectively. So that caregiver should be prepped and ready, okay, before the visit even happens. So if there's any words of encouragement, it should be during the procedure. You're doing a great job, excellent, good job. You want to be cognizant of potential bribes. Okay, so a lot of times I think it's like 90% of patients will come in and mom is already, for neurotypical patients really, but mom is already giving the bribe of, oh, we're going to go to McDonald's and get ice cream after this, or there's always something that they're about to give them, and it's oddly always some sugary something or other, which is always funny for us to hear, but you want to be cognizant that those caregivers are potentially going to reward them before you even hear it. You can say to the parent, don't do any bribes, but that's really their business. What you don't want is during treatment they go, we're going to get ice cream after this, we're going to get ice, that can throw them off, because what they're looking at it is, okay, this is a challenging situation, that they have to somehow get through. And so we don't want to make it like it's a challenging situation that they will get a reward for. So we want to make sure the caregiver's on the same page with that. All right, and the parent really should only be helping you in your treatment. I'm going to speed up a little bit because we don't have so much time, but I want some time for questions. But let's talk about nonverbal communication. This is what we've been waiting for. Safety first. We know that we were just talking about it before with our behavior management goals, but safety really is first. And you can see everything that we're using. This is a molt prop up here, this little scissor-looking thing. That's if you have a little bit of space and you need to open the patient's mouth up a little bit more. This is a bite block. We use that for almost every patient, be it neurotypical or a patient with IDD. And this also keeps their mouth open. This allows us to effectively look at the mouth without the patient biting down, basically. And that is probably one of the biggest tools that we use once we have the patient in protective stabilization. Even without that, if they don't need any kind of protective stabilization, we almost always use a mouth prop to keep the patient's mouth open, even in neurotypical patients. What you need to realize is when Dr. Ferguson, I love this, is that when he's putting the patient into the arm guards, it's a sort of a song and dance, especially with patients that he knows, okay, the patient's almost like ready to get into those arm guards because they've done this before. So that was that second visit with that patient, which is incredible that they kind of let him even do it. But not every patient's going to be so willing. Some patients like it. Like I said before, there are autistic patients actually that really like the control of the papoose. They like being almost like swaddled like a baby, and it helps them feel like the situation is controlled. It kind of maybe cuts off some of the extra senses that they may feel if they didn't have that, kind of the wrap on them. And so it's very important that, we look at all these things as this is also part of nonverbal communication. Also putting it on and taking it off, like I said. So it's a kind of a song and dance, putting it on but taking it off. This video didn't show it as much, but I know with my training, you don't just rip everything off and let the child run out of the room. You kind of take everything off in a systematic way so that the child or the patient knows we take these off when we're ready to go. Everybody's in control. Everything's good. But it's also somewhat of a positive reinforcement. Okay, we're relaxed. We're going to take the next thing off. We're relaxed. We're going to take the next thing off. So putting it on, taking off also has implications of nonverbal communication. There's comfort and familiarity with a lot of these patients. Holding those buses that child had was awesome because that child was able to see that, they have some control of their own. Oh, you're going to do dentistry? You're going to work on my mouth? Well, I get to hold my toy, okay? So, or I get my toy after I do a good job. That's a little bit of positive reinforcement. So it's good that it's a little bit of a give and take, and you can let children kind of have it as long as it's not too, distracting to your work, or it's not going to, impinge on your your safety gear or anything like that. That first child had headphones on, so that's something that when they walk in, that's good. They can have headphones on. Just be aware. We'll talk about technology in 2 seconds when we get to after I get through this, but just be aware that technology can work for us or against us. You want to try to do the same routine every time. So in these 2 visits, the same routine was kind of employed. It doesn't always go perfectly, but it's nice to know that that child may be aware that these steps are coming and they may be ready for it. As dentists, we're fortunate. We get to see patients twice a year, so we're able to maybe usually form some sort of rapport, depending on the intellectual level of the patient. With that patient, they may remember us. Again, it could be great if there was the same provider every time. If you see that patient for 20 years and they remember, you could have such a great relationship, and treatment may always go very well for you, and the caregiver's on the same page as you, so that home care may be perfect. So that has a lot to do with dentistry, but I would hope that in medicine and other healthcare professions, we see that too. If that caregiver is on the same page with you and they trust you because you're with that patient every time, everything gets done in a very productive way, a very effective way. So technology can be great. iPads are the thing, and it's wonderful. However, if that child is coming in with an iPad and that's the only way they will open their mouths is if they're watching the movie Frozen, I'm a little concerned with how much they're focusing on my treatment or my way, because what I like to think of is that everybody gets treated the same way. I have some rules. It's my house, as Dr. Ferguson likes to say, because that's what he's always taught us. It's your house. You make the rules. If you want to have a TV in your office, that's great, but understand that child may not be focusing now on what you're saying to them. All right, so I would recommend, if you have a patient that loves the iPad, maybe after the first or second visit you can let them watch the iPad, but for those first visits, have them hold a hand mirror. Have them hold that mirror that you saw in that video. Let them see what's going on with their mouths that you're doing. It's not so bad, that also gives them some control, that they have control over what they can see. All right, so, and then technology, Dr. Ferguson actually mentioned to me the other day that a lot of parents are coming into his private office and taking pictures of like the building, the waiting room, the dentist, so that the child, when they're home, be it 2 or 3 days maybe before, they're looking at those pictures and prepping the child for what's to come. All right, so the always keeping a hand. I got a lot of questions about this. So the hand on the patient and the contact, very big thing with Dr. Ferguson, and it works usually very well. And a lot of patients were saying, a lot of people were saying, sorry, in the questionnaire, why, what if you have a child that cannot have kind of physical contact or something like that? You're going to gauge that with the discovery part of things. So the reason why you're putting a hand on the patient is to see if they can, even if they're going to kick your hand away, if they're going to get uncomfortable, if they're going to freak out, run out. I mean, you have to see that first, but why not try it? And a lot of times that physical contact keeps that connection with that patient. It keeps you in control, and it gives you, there's always something in physical contact that gives you a connection. And with a lot of these patients, that sense, so we're kind of using that over-selectivity sense to say, we're here with you, okay? And usually it works. It depends on the patient again. You have to use that discovery part of things to figure out if that patient's going to like that. The gender of provider versus gender of patient. So the gender of the provider, be it a male or female, may not be appropriate for the patient depending on the patient's history. So if the patient has been sexually abused by, it's a female, they've been sexually abused by a male, or whatever it is, that should be done way ahead of time. I'm sure it would be. The caregiver should maybe mention that the second you meet. But usually it's not a problem. I've never really encountered a problem. The only thing you have to be cognizant of as any kind of healthcare provider is what's appropriate and what's not. We are already in a very close setting with our patients, and we are already putting our, doing things in very close physical contact with them. And so usually patients, if they're informed ahead of time, caregivers informed ahead of time, they're completely fine with that, and it actually works out very well for us. We then want to control the surroundings. We were talking about, again, over selectivity and lights and sounds and smells coming at all different, all the different senses are ignited. And we have to be cognizant that even a light in a neurotypical child's eyes could throw off an appointment. So just be aware, music can affect a child. It could be a good thing or a bad thing. Be aware of all these different surroundings that could trigger anxiety potentially in any of these patients, which is a little bit more easily triggerable in these patients. The parents' reaction. These parents, again, were so on board. Anything, like we said in the very beginning, anything, you may not know the nonverbal communication between that patient and that parent, and it's important that you realize that that patient's the parent's reaction has more weight than anything you will do. That parent is afraid, that child 99.9% of the time is going to be afraid. Okay, we realize that a lot with pediatric dentistry, and it's more than likely the same in IDD. And now I'm a first-year pediatric dental resident, but I have seen that in my short-term amount of clinical practice, and I know Dr. Ferguson would more than likely, he has said the same exact thing, that that parent or that caregiver will kind of impose their feelings on that patient non-verbally, without you even realizing. So make sure that parent's on board with you. Transition time is important because we want to make sure that things are going a little bit slower for these patients, and we want to make sure that they are trusting us that if we get to the next step, they're ready for it also. So be very cognizant of that. The last thing I want to leave you with is don't give up. And this is very important. I know it's very short and sweet, but it really is important. So you're going to want to do things, again, intuitively. Child screaming, crying, you want to stop because you feel like that child is going to, I don't know, burst a blood vessel in their head if we don't stop. Not usually the case. That's why medical consents are got. If there's something, heart condition, you want to make sure that child's not turning blue. That's a totally different story. Most children are if they're healthy enough to, scream and cry at home, they're healthy enough to scream and cry when they're in your office. That's something, again, ahead of time, you should be making sure that that's safe. However, you have to realize that if you do stop when that patient is screaming and crying, you're doing yourself a disservice. You're telling that patient it's okay to cry, first of all, and it's okay that if you do this, this, and this, we're going to stop. And they can get the heck out of there if they wanted to. So you want to make sure that you don't do yourself or the next provider a disservice by stopping and trying your hardest to get to the end of the appointment. It's really important. Trying to gain that confidence, because every patient you do see, every appointment you do finish successfully, you gain more confidence and experience. I get the question a lot of, if the child is freaking out, what do we, how do I not stop and how do I ignore it? Know that it's somewhat normal. There's a difference between, again, an anger and a frustration cry versus a pain cry. In dentistry, we can kind of pinpoint exactly. It does come with experience, but you know that if you're on a certain tooth and there's a difference between pain. Usually brushing teeth or doing prophies or doing exams doesn't cause pain, so you know that that child's crying, they just don't want to be there, and you have to make sure the parent is aware of that. Again, with informed consent, if you make sure the parent knows that your child will kick and scream, your child will be very upset. These are all potential things that may happen at the dentist's office. If they know that ahead of time, they can say, all right, they're not in pain. I can, the dentist should keep going, and they should be encouraging you. They should be your cheerleader. They should be right next to you and having that shared vision of how the outcome of this this clinical appointment should go. So you want to calmly tell them that nothing's hurting them, their child is safe, and that we're going to keep going. Okay. And there's always limits, but you try your best to gain that parent's trust, because if you do finish that appointment successfully, what a great day that is. And that honestly is the end of my presentation. I do have my email here if anyone wants to ask me questions. I had a few people asking me about maybe past things that I've done as far as like with special needs. I actually don't have any relatives that are special needs. I just have a passion for it because Dr. Fred Ferguson is so passionate. He just inspires all of us. And I just want to thank Dr. Anderson at Harvard, Dr. Ferguson, and Dr. Tarr, Michael Tarr, who's a medical student, for doing this. I actually put Dr. Tarr. Isn't that funny, Michael?
I'll take it.
I also just want to encourage everyone that to try and gain confidence for patients with this, because they are so underserved. And I hope that in the dental setting, because of all the closeness that we have, in the personal space, that maybe some things can be extrapolated and some techniques can be used in your clinical practice, because it is our duty to treat these patients. It's their right to be treated effectively, and we have to get the word out and the training out that these patients will be treated just as every other patient is, with the standard of care that every other patient is. And I want to thank everybody. Michael, should I go into some questions, even though we don't really have time?
Oh, yeah, we have time, for sure.
Okay. I wasn't sure, because I know it said 9:30, but I know everybody has probably...
If anyone would like to sign off, they're obviously welcome to, but if people have questions they want answered, then they should feel free to stay on.
Absolutely. So I hope the constantly touching him question got answered. And I hope the one about the, what if patients are touch like intolerant got answered. If they're not, just please, send that question again, if you could. The other question I got, Okay, someone said, adults like the papoose, I always explain that it's no way for behavior management, but for safety. I never raise my voice when getting the patient into Rainbow Snuggie. So that's actually great. One of the askers said, the attendees said that they call that wrap a Rainbow Snuggie, which is amazing. I love this, like, because that's exactly what it is for a lot of these patients. And it is good to not raise your voice, because then maybe they would associate getting into that wrap with a sternness in your voice. And again, I think that was the same person that said that it's you know, it's together, the verbal versus the nonverbal when you're treating patients, and that's an awesome point, and I really appreciate that person mentioning that.
Let's see. Oh, also, just in the meantime, I want to point everyone's attention at the chat box. At the end of the presentation, if you'd like to follow the link to the survey, it's just like really quick. Answer whichever questions you would like to. You don't have to feel pressured to answer all of them. Just the more information we have, the better we can make this and these presentations for you in the future.
Yes, please do. Someone said, are you aware of studies done on cumulative trauma from this type of approach to care? Very good question also. So I'll be honest that my training, I have only heard that research has been done for long-term studies on trauma or psychological damage due to this type of care. And from what I've heard, and again, this is strictly what I've heard and not looked at myself, so I can't say that it's fact or even, you know, research, and I feel kind of silly even for mentioning this, but I've always been told that it does not cause psychological harm to these patients in the future. However, I know in my personal experience with my aunt, the only thing she remembers about the dentist when she was a child, and she is not special needs by any means, she's neurotypical patient, she does remember being strapped to the chair as a child. However, she understands at this stage in the game, and she said even by the time she was in her teens, it wasn't traumatic. It was just something they did when she was younger. You know, it wasn't traumatic. It does. So I would really like to talk to Deborah. Can you email me? Because I would like to know if you have any information about that, and I would, and I could even send that out to like the group or something about that, because it's very interesting.
I think like on that front, a lot of the times, you know, you have to argue necessity.
Yep.
Because I mean, in medicine and dentistry, we don't treat patients because it's fun. We treat them because, you know, people need treatment. You know, it improves their health, and it's absolutely necessary. And we do certain techniques like this to minimize the amount of medications you're giving to a patient. Obviously, there's an incredible amount of side effects from anesthetics, and some people have bad side effects from them. Some people have bad allergic reactions to them. And if you can normalize a procedure in any medical or dental field and really get a patient comfortable with their healthcare provider, then it will really change the patient, or hopefully, you know, it's not always going to be 100%, but you're going to change a patient's perspective on going to the dentist, going to the doctor, and then maybe hopefully in some of the cases you won't even need, the parents won't need to bribe their children to go, or you won't need to have always a reward system, because you're reinforcing them, like you said, always having that that physical contact with your patients, and letting that, having that intimate connection where you're saying like you're building the trust with them, and saying like, I'm doing a good thing for you. And it might be scary. I mean, I don't always enjoy going to the dentist, but you know, I enjoy communicating with my healthcare providers because I know what they're doing is good. And that's kind of, I think, what we're trying to do here is break down those barriers.
Absolutely. And to kind of talk about that too a little bit, is just that as Dr. Ferguson kind of had in that video, there's that child, when he was much younger, was in that papoose and now is only in arm guards and leg guards. So as time goes on, they may not even need it. It becomes, you know, they become more comfortable, they're more aware of things and trustworthy of the provider, so you may not always need that protective stabilization every single time as they get used to coming to appointments. Let me just see if there's any other questions. Someone said, you've spoken quite a bit about children and experiences with adults in protective stabilization. So yeah, we do a lot of, in my training of, as a student, even now in residency, we do developmentally disabled clinic, like a DCDD clinic, which is mostly adults over the age of 18. And so we do the protective stabilization. It's the same sort of thing where you're getting the patient into that protective stabilization in a certain way, talk to them in a certain way. It kind of all relates. Children, they are somewhat like-minded with children, as we know. Not always, but typically you can use a lot of those same behavior management techniques with the adult patients as well, and they typically do very well. You may need more handlers, you know, you may need a able-bodied man or someone to get them out of their wheelchair and things like that, but usually it's the same kind of song and dance. I hope that answered your question. If a parent said knowing their child, if a parent said knowing their child as they do, it would cause psychological trauma, do you back off and go to sedation or OR? So the bottom line, right, is always if there's this is my opinion that the provider should always dictate treatment, obviously with its limits. So if the parent is really adamant about not wanting to do any kind of protective stabilization because they feel it will cause psychological trauma, it's our job to inform them, obviously, of what the benefits and risks of it are. And after that, after all the consent, all the informed consent and everything that you can get, if the parent still doesn't feel like they want to do that, then that's still their child or the caregiver. It's that's their the patient's in their care. So it's really, that's the bottom line. It's up to them. You can't obviously force anybody to do anything, but it's our job to make sure they're informed of the benefit of all these things, of doing it in a clinical setting and not putting a child under general anesthesia and drugs and things like that, for the reason of any health care, obviously, unless it's completely necessary. And in dentistry, it is sometimes necessary. Let me see. I've worked with patients for 30 years in public health, and the last 7 years at IDD. I've not seen that there's any detrimental long-term effects from any protective or physical stabilization. Any detrimental effects, in my opinion, is from the emotional mistreatment, which is why positive verbal communication is as important as nonverbal communication. I love this. So this is so perfect. It's true. I think that was such a big point. I think this was the same person that said it's the verbal communication with the nonverbal. So the nonverbal being the protective stabilization, let's say, and including that there's positive reinforcement as you're doing the protective stabilization. You're not yelling. There's no voice control being used. And that in combination, if the patient has the ability to remember these things, there shouldn't be any psychological trauma because they're associating it with a positive experience. It's just, nothing's hurting. It's just stabilizing them. So great point. I love this. This is awesome. Someone was mentioning the adults with their size and strength is an issue. Unfortunately, we all got to be nice and strong and healthy with a lot of these patients because they have this monster strength sometimes that is, like bigger than, I've had some of my guy friends in dental school who work out every day, sometimes struggling because and it's children sometimes that they're struggling with. They could just have this incredible strength, and unfortunately, there are situations that I've had where they're emergency situations, or they're just situations where that child, there is no way you're going to be able to coax them and talk them through getting into that chair slowly and controlled and everything, that you just may have to get them in that chair, put them in those wraps. Everything is with intent, but again, kind of what this person is talking about, there shouldn't be voice control or anything used. They may be kicking and crying and screaming, but you're kind of just doing everything okay, we're going to get into the wrap, and we're doing a good job, all right, but we're going to go slowly. They could be screaming, but you are cool as a clam. You're trying to do the best you can to keep it all under control, at least on your end of things. However, putting everything on is quick and fast and with strength to get them in a protected stabilization device. So, that's a great point, though. Yeah, size, unfortunately, can be an issue. Size and strength, these patients can be an issue. I think that was all I had. If anyone has any other questions, I see some people I'm going to send emails to and stuff like that, which is awesome. But I think that was it, Michael. So
Great.
I really appreciate it. Thank you, everybody.
Thank you, Kelly. Thank you so much. And everyone, if you have the flyer that you used to register for this, you have my email as well. If you have any general questions about virtual grand rounds, if you're interested in presenting one in the future, or if you have any questions in general about treating individuals with intellectual or developmental disabilities, please feel free to email me. I'm going to write it in the chat box as well, just in case you don't have access to the flyer. And with that, I just want to say thank you so much, Kelly, for presenting for us tonight. And I would also like to thank all of our participants for taking their time out of their night and joining us tonight.
Okay. All right. Have a good evening.
All right. Good night.